We have no relevant disclosures. So there are some new things in IBD-related cancer prevention. So pay attention. I know it's post-prandial time, but we actually do have some important and new information for you today. First of all, there have been completed some longer and the longest studies of the natural history of IBD-related cancer. Second, the incidence of cancer related to colitis has actually decreased over the years, so we have to think about that in terms of our use of our available resources. Third, risk factors continue to be clarified, and we now can start stratifying patients into higher and lower risk groups. Fourth, our imaging technologies have improved, as everyone here knows, and I know you're all waiting for us to tell you whether you should be doing chromoendoscopy or not, and we will address that. And last, sorry Neil, but we're moving away from total proctocolectomies. We're doing less surgery in some patients, and you want to know, I'm sure, which patients those should be.
Thank you for the introduction. So as Dr. Rubin mentioned, there's been a lot of advances, but there's still some ongoing questions about screening and surveillance, and we're going to address some of these questions today. So one of the questions we'll address is who is at risk, what techniques should be used, what is the optimal method of detecting dysplasia, when should we do random or targeted biopsies, and when should chromoendoscopy be performed. The last question we'll address is when active surveillance is appropriate instead of surgery. So first, who's at risk? So it's been well known that IBD patients are at increased risk for colorectal cancer. This is a historical meta-analysis that looked at UC patients and their risk of developing colorectal cancer. They showed here that at 10 years of disease duration, these patients had a 2% risk of developing colorectal cancer. And at 20 years, it went up to 8%. And at 30 years, it was 18%. However, at a recent meta-analysis that looked at 9 population-based studies, they showed the risks to be much lower than previously described. The 10-year risk was 1%, and the 20-year risk was 2%, and the greater than 20 years disease duration went up to 5%. Importantly, as you can see in the purple graph right here, they show that patients at referral centers had much greater risk of developing colorectal cancer, and they attributed this to greater prevalence of risk factors by virtue of these patients being at referral centers. So what are these risk factors? Some are patient-related risk factors, such as longer disease duration, greater extent of disease, the patient having PSC, or family history of colorectal cancer, increased degree of inflammation, and being a male. And some of the dysplasia-related factors are having a high-grade dysplastic lesion as opposed to low-grade, having a flat lesion as opposed to a polypoid, and having the lesion being detected on random biopsies or being invisible as opposed to a raised lesion. Also having multiple lesions as opposed to a single unifocal lesion. In this month's issue of the American Journal of Gastroenterology, the St. Mark's group from the UK presented their data from the longest surveillance study of UC patients, and they showed that the rate of UC patients developing colorectal cancer, the incidence rate has been decreasing over the last 4 decades. They also show that of the cancers that are detected these days, there is a lower proportion of advanced cancers being detected. So why is the incidence rate decreasing? So it's possible that secondary prevention is more effective as surveillance colonoscopies identify lesions that can be resected or result in surgery. Or it's possible that primary prevention is being more effective as medical therapies are better in controlling inflammation and then reducing the risk of progressing to colorectal cancer. So our message is that we should manage the patients or manage the disease and perform surveillance as effectively as possible. But the question is, what is effective surveillance?
So we're going to use a case example to demonstrate how surveillance can be most effective. This is a patient from our practice, a 35-year-old woman with pan-ulcerative colitis since she was age 27. She's in stable remission on mesalamine once daily, and her last flare was about 3 years ago that required a short course of corticosteroids. She has no significant past medical history, and specifically, she does not have PSC. There's no family history of colorectal cancer. And she's here now for routine clinic follow-up, and you discuss with her the time to start cancer prevention. So what technique should we use, and what is the optimal method for detecting dysplasia? Well, let's look at a table of the available guidelines, and we're going to focus on the U.S. guidelines, which I would suggest to you, and I've actually written about as being out of date. Nonetheless, the AGA and the ACG, both in 2010, remind us that we should start screening and then surveillance after 8 years of disease. The interval for follow-up is variable based on different risk factors, such as PSC, which certainly requires annual screening and surveillance as soon as you know they have it, versus other patients in whom you may wait longer in between exams. Of specific interest is whether or not you should be doing chromo, and the available guidelines, I'll remind you, do not say chromo is recommended. In fact, it's acknowledged that it's for special cases only by the AGA, and in an accompanying technical review published at that time, they said that this is really for special cases and only by endoscopists who have experience, which makes sense to us, but certainly doesn't put you as a practitioner on the hook for doing it. I'll point out separately to you that the BSG did endorse recommending chromoendoscopy in all the patients that they're scoping with not such great data, but we'll come back to that concept. And ECHO in 2008 acknowledged that chromo was better than white light, but didn't go so far as to say it should be done in everybody. So at least based on available published guidelines and specific to the United States, it's not yet recommended that you do chromo in everybody. However, there's a few things to keep in mind. Now, this was published simultaneously in the GI Endoscopy Journal and in Gastro this year. This is the summary of a consensus meeting that occurred last year. I had the fortune of being involved in it, called Surveillance for Colorectal Endoscopic Neoplasia Detection and Management in IBD Patients. The consensus meeting brought together an international group of gastros, surgeons, pathologists, and there was even patient representatives in the room who not only performed a systematic review and in some cases a meta-analysis of specific questions, but then the group voted on statements related to how we might manage our patients. We're going to use this particular scenic document now to guide us through the remainder of our presentation and point out to you where the evidence is low, where it's very low, and what our take-home messages might be. So I want to point out to you that the consensus statement published called Scenic is not a guideline. This is just a review of the available evidence with some opinion pieces within it. So the first statement within the consensus statement of Scenic is that when performing surveillance with white light colonoscopy, high definition is recommended rather than standard definition. Low quality evidence, but most of the people present at the meeting thought that this made sense. Let me ask our audience here today, how many of you are using high definition colonoscopes in your practice? Okay, good. How many here still have standard definition equipment in your practice? A couple people, but the majority are at high def. So the available evidence is retrospective studies comparing dysplasia detected in one group of patients who had high def versus another group who had standard def. Not great evidence, certainly not prospective, but nonetheless, it's currently recommended that high def would be preferred. In our case, to get back to it and illustrate the point, you start by risk stratifying the patient. We considered this patient to be low risk. She's not at no risk, of course. She's had disease for 8 years. It's a woman, not a man, and she had mild disease activity previously. The video is a representative video of a high-def scope. You can see that she's in clinical remission, if you remember, but there's still some erythema you might appreciate given the resolution on a high-def scope like this one. So the next question you want to know is, should we still be doing those darn random biopsies, right? The random biopsies came about with the idea that we couldn't see dysplasia, so we should sample the mucosa in some systematic way. Coming out of the colon, you take biopsies every 10 centimeters with the idea that if there's dysplasia, you might stumble across it. Well, we have to acknowledge that that's really not a very good way to do things. And in fact, we know, and this is using standard definition scopes, that both from that St. Mark's group in the UK as well as from our group in Chicago, most dysplasia is visible. And that was with standard def scopes. So in retrospective review of our sets in those two different centers, we saw most dysplasia. And if you only counted finding one lesion as being important to make management decisions, that's what we call a per-patient sensitivity. It was even higher. In other words, doing random biopsies was not really very effective, and we could see most things, like the cancer you see on the left, and the other picture is actually retroflexion in the rectum with that spreading flat lesion across the whole bottom, which was low-grade dysplasia with an inflammatory polyp right in the middle of it. So in the scenic statement, I'll zoom in for you here, they looked at the available data and consistently targeted biopsies found more dysplasia than random, no surprise. And the number was similar to, or maybe higher, than what was even seen with targeted biopsies using chromo, although this wasn't comparing those two techniques. That's important to keep in mind. So you can keep in mind here that random biopsies are very low yield, but the scenic guidelines didn't go so far as to say we shouldn't do any more random biopsies. The group recognized that there's some disagreement and we need more evidence.
So let's look at another case. This is a 50-year-old male with ulcerative colitis since the age of 28. He's been maintained on infliximab and azathioprine. He presented to clinic with 3 to 4 stools per day with occasional blood and urgency. And his last colonoscopy 2 years ago showed diffused mild inflammation throughout the colon and the rectum. Random biopsies did not find any dysplasia. So we'll stratify this patient to be in moderate risk, given his risk factors. He's a male with a 22-year disease duration, moderate disease activity on his last colonoscopy. So he had a screening with high-definition scope, and this is the lesion that was found. He underwent chromoendoscopy to better visualize the margins, I should say. So the question is, when should chromoendoscopy be performed? The scenic publication addresses this, and they state that when performing surveillance with standard definition colonoscopy, chromoendoscopy is recommended rather than white light. And they based the statement on a meta-analysis of 8 trials that they did that showed much greater proportion of dysplasia being detected using chromoendoscopy as opposed to standard white light. So back to our case, we use high-definition scope. What does dye spray chromoendoscopy add to high-definition scopes? They addressed this as well, and they said that when performing surveillance with high-definition colonoscopy, chromoendoscopy is suggested rather than white light colonoscopy. However, the emphasis here that it is suggested. And this was based on low-quality evidence, and this is only a conditional recommendation, as this is still being studied. And actually, in the most recent DDW meeting, there was a study that looked at the difference between high-definition endoscopy and chromoendoscopy in detecting dysplasia, and really they showed no difference between the two. As you can see, high-definition endoscopy is in blue here, and chromoendoscopy is in maroon. And they showed that high-definition scopes were actually better in detecting raised lesions.
So it's probably not something that you'd use for all your patients, nor do we recommend it. At U of C, our approach currently is for selective patients. If you refer someone to me who's had previous dysplasia, I will use chromo when I go back in to try and make sure I'm seeing what's there and finding things that you might not have seen. Or if you're learning chromo and want to do it, I would say you identify specific patients. It's very important that they be clean in terms of their prep. So I emphasize a split dosing prep for these people. And when I can in my young patients, I still use the sodium phosphate tablets prep, which to me is one of the cleanest and nicest preps. It's also important that they not have inflammation. It may be true that you can find raised lesions when there's inflammation, but chromo from a dye spray point of view really is lousy when there's active inflammation. I prefer methylene blue. There's been some discussion that there may be some DNA changes that occur when you use this dye in animals. There's no human data to back that up, and the dose is so low, it's diluted. My recipe there is 2 10-milligram vials in 250 cc's of saline or irrigation fluid, and I've been using a power wash for years. As soon as I figured out to use the power wash, that leaves your instrument port open so you can pass your biopsy forceps. So on the way in, I clean. On the way out, I spray, and I do targeted biopsies. And just to anticipate a question, yes, I can do an entire chromo exam and take 0 biopsies and feel pretty confident that we haven't missed something. That's not yet in any guidelines. And if you're not comfortable or sure, then certainly you can stick to doing some random biopsies. If you were watching this video, you'll see that I did a biopsy, and as soon as you do a biopsy with blood, the methylene blue mixes with it and it becomes black and it becomes harder to see. So be careful when you start doing that. You got to get some more experience doing so. But we're very happy with the way this dye works. It's distinct from indigo carmine, as many in the room know, because methylene blue is a absorptive dye, while indigo carmine is a surface dye. And so I don't have to roll the patient around. I let gravity do its job. I spray at the top, and as it drips down, it gets absorbed beautifully to give us the images we need to see what we want to see. Now, I want to point it out that in the same issue of the American Journal of Gastro that Noah just mentioned to you is an editorial that Peter Higgins wrote, and since he was here today, we wanted to give him a shout-out, even though I thought he might take off. He's here with his family. But he pointed out that if we used chromo to identify all the dysplasia that we think we've been missing, we're going to end up diagnosing a lot more people with dysplasia, and the question really is that a relevant endpoint? And we agree with Peter's comment, and that's part of what we're here to tell you, which is that if we really were missing all this dysplasia, where are all the cancers that we've been missing all these years, right? So if we've been doing what we thought was the right thing and we're missing dysplasia that was relevant, there should have been occult malignancies popping up more often in our practices. Now, it is true that interval cancers are discovered and do happen. But it's not nearly at the rate in which the chromo studies would suggest they might be if all the dysplasia being found is relevant. So there's a couple possibilities. One is that the dysplasia we see with our better imaging techniques does not have the same predictive value of the old-fashioned dysplasia that we all learned about. And we think that's probably true, and Noah's done some nice work to look at that. The second possibility is that dysplasia that we find this way is either being inhibited from progressing or may even be regressing. So what you really want to know is, are we preventing cancer by doing this? And there's very limited follow-up. In all those studies that were looked at in the scenic guideline or scenic consensus statement and in other publications, there's only one study that tried to look at follow-up, and this is Jim Marion's study from New York. 5 of the 102 patients in this study went to surgery for unresectable low-grade dysplasia, and they found no cancers. Now, we have a much larger number in our study from Chicago that Noah will mention to you. Now, getting back to her case, you can see the white light lesion highlighted with the arrow, followed by the highlighted part using chromo. This is an example of using chromo just to give you the margins of a lesion you identify otherwise. So you may not need to do it in the whole surface area of the entire colon. In this particular case, what I then was able to do is an endoscopic mucosal resection. It was low-grade dysplasia. I was probably a little bit too vigilant to decide to use endo clips to close the defect. But I'll tell you, there was no other dysplasia found, and in this patient, 2 years of follow-up with what we call active surveillance, there's been no additional dysplasia. So at least so far, this patient has had a very good outcome. So what you want to know now is, when can you employ active surveillance versus sending them to have a proctocolectomy?
So when is active surveillance appropriate instead of surgery? So first we should answer the question, what is the risk of cancer in patients with low-grade dysplasia? And we can look at this in 2 ways. One is, what is the risk of patients with low-grade dysplasia to have either cancer underneath the dysplastic lesion or elsewhere in the colon at the time of detection? And the other way to look at this is, what's the risk of the low-grade dysplasia progressing over time to cancer, which we term metachronous cancers. So historically, low-grade dysplasia was associated with 19% risk of synchronous cancer. However, this year we've looked at patients with low-grade dysplasia that underwent colectomy and saw that there were 0 patients there were 0 synchronous cancers on the colectomy specimen. In regards to metachronous cancers, in the past, they were thought to have a very high rate of progressing to advanced lesions, but in recent years, the rate has been shown to be much lower. And in 2010, a study from University of Chicago looked at patients that had both polypoid and flat low-grade dysplastic lesions and saw that there was a very low rate of progressing to colorectal cancer when it was a polypoid lesion that was resected, and a low rate when it was a flat lesion. However, it wasn't 0. So in summary, these studies are showing that low-grade dysplasia has a very low risk of progressing to colorectal cancer. And we think that this is most likely due to the advancement in our optical technologies. The CNIC consensus addresses this, and they stated after complete removal of endoscopically resectable polypoid dysplastic lesions, surveillance colonoscopy is recommended rather than colectomy. They also state that after complete removal of endoscopically resectable non-polypoid dysplastic lesions, surveillance colonoscopy is suggested rather than colectomy. And these are both based on very low quality evidence.
So you may be wondering, what do you do about the endoscopically invisible dysplasia that's found either by your random biopsy or by some other technique? If it's confirmed by a GI pathologist, the recommendation was that you refer this patient to an expert who can perform chromo to better visualize and see if, in fact, what you found on random biopsy is actually visible using another technique to better stratify the patient and make some recommendations. However, we'll point out to you, just like the last two statements from CNIC, and a major criticism of the entire document is the low quality of evidence to make this recommendation. So once you find dysplasia, how do you approach it? This is a nice summary. Jerry Turner is one of our GI pathologists, and I've modified this algorithm we published a number of years ago for today's presentation. Dysplasia is identified if it's endoscopically visible by white light or it's raised in some other way that you find it, and you completely remove it. The consensus statement, as well as our practice recommendations, would be that you follow that patient with active surveillance and keep them on a close watch. I would also recommend that you would use chromo or recommend that they have chromo. If, on the other hand, the endoscopic appearance of the dysplastic lesion was flat, which I've modified here to define as either picked up on a random biopsy or was visible when you did chromo. So it's a distorted pit pattern, or one of the things that we didn't have time to teach you about today, but we will be in the future. The next question is, what grade is it and how many lesions are there? If it's low grade and it's unifocal, ongoing surveillance is currently recommended, but getting a surgical consultation is important. If it's multifocal, and certainly if it's high-grade dysplasia, we do recommend surgical resection and removal of the target organ.
So in summary, we presented an updated approach to surveillance. The risk of cancers in IBD is now lower than previously described, involving optical technologies that made identification of dysplasia easier. As we described previously, random biopsies for surveillance are of limited utility, and not all dysplasia requires immediate colectomy. So we recommend that you stratify your patients by individual risk factors and consider chromoendoscopy when standard definition scopes are used. If you're scoping a higher risk patient, if the patient has confirmed dysplasia, or if you found a lesion that you want to better clarify. And if in doubt, don't hesitate to get a second opinion from either an IBD endoscopist or a surgeon. Thank you.
Great job. Okay, well, thank you very much for your attention, and I hope that you were able to pick up on some of these new approaches and this nice summary that Noah put together for you guys today. Terrific.